Hello students, I'm Dr. Punit Bhojani, the OG Guru, and welcome to the session. First of all, wishing you all a very happy new year and a very successful new year. May you achieve all the success in this year. Now, do subscribe to the channel if you haven't already subscribed. Now, what is the plan of action for this video? Okay, you can also see this video at 1.5x to save the time because it is the time is very crucial and you will definitely benefit from the video is my guarantee. So point number one, we are going to I'm going to right away give you the list of must know OBGY topics for the upcoming FMGE examination. Okay, and in the last 15-16 days, what exactly you need to study for gynec and obstetrics and which are the most important must know topics. This is based on my years of experience, and trust me, every year students tell me that sir, each and every MCQ in my exam were from your lectures. So based on lots of experience, I'm going to give you the list of must know topics in gynecology and obstetrics which you should study in the last 10-15 days, and that will help you score the maximum marks in your OBGY for FMGE. Okay, and it's one of the major subjects, minimum 30 questions, and students were lucky couple of years back 35-40 questions were there from OBGY, and they called me and told me that sir, thanks to your lecture series we even cleared FMGE only based on OBGY. Okay, because one subject you get 30-40 all MCQs correct, passing becomes very easy. Okay, so first few minutes I'm going to give you the list of must know topics of OBS and gynae, which is a very important list for the upcoming FMGE exam, and then we are going to discuss the top 20 or the must know. So it's like an ultimate revision program is there for your upcoming FMG examination, where the top 20 MCQs from the most important topics, of course, I will be covering. It will be a mix of both gynecology and obstetrics, and including image based questions are there also at the end. So stay right till the very end. So even this video itself is going to give you a lot of information, and many questions are expected from this video itself in the actual examination. Okay, so let us begin our discussion. And first, let me tell you the list of must important or the must know topics in gynecology. So when we start with gynecology, infertility becomes very, very important. And by this infertility, mainly questions are coming on female factors, specifically PCOS, and something to do with endometriosis may come. But very, very important is PCOS topic. And equally important in infertility is your test for tubal patency. So tubal patency test. Also go and see my YouTube short which I have discussed about the tubal patency. Okay, so tubal patency test, and very important hysterolaparoscopy, HL scopy. So Mullerian anomalies and HL scopy, definitely questions are coming. There are questions on this also. We are going to start now the discussion in some time. So when you see the MCQs, we have based the questions also on this way only. So hysterolaparoscopy, Mullerian anomalies, all this becomes extremely important. So infertility, PCOS, endometriosis, tubal patency, HL scopy, IUI, IVF, ICSI, so much questions are not coming, but these are extremely important. Male factor, occasionally a question may come. Second, very, very important is also the topic of contraception, specifically with the focus on IUCD, OC pills. All these are extremely important, and definitely questions on contraception, it's like a must know topic. And the most important, then moving on, very, very important, the topic of amenorrhea. In this amenorrhea, secondary amenorrhea is almost hardly ever asked, but primary amenorrhea. So we're going to discuss a couple of MCQs on this topic also. So primary amenorrhea becomes extremely important topic, and definitely questions are coming on this. So trust me students, even if these three topics you master, your entire infertility, contraception, primary amenorrhea, majority questions in your OBGY are going to come from this. And definitely one MCQ to two MCQs from the topic of very simple infections, the different vaginal infections also. So these are the most important. Fibroids, occasionally, yes, fibroids may come. Menorrhagia, again very important. So I've picked up a MCQ for menorrhagia also. Prolapse, again I'm going to discuss the most important and the likely question from prolapse also. So that's it. And yes, cervical cancer. So CS, cervix, all the cancers you need not, but cervical cancer. So trust me students, even if you focus on this 5 to 6, 7 topics, infert, contraception, primary amenorrhea, infections, fibroids occasionally, menorrhagia occasionally, prolapse occasionally, and cervical cancer. This should cover your 90% or 95% of gynecology from the upcoming FMG, or even 99%, I can say for sure. This will, all your questions will be from this only. Okay, but remember, infert is huge. It's not only one infertility, everything: PCOS, endometriosis, tubal patency, uterine factors, mainly focusing on HL scopy, HSG. All these are the important parts of your gynac curriculum for the FMG examination. Okay, so infert, contraception, amenorrhea, infections, menorrhagia, prolapse, fibroid, and cervical cancer. Urogynac, SUI, all that you can just leave it aside. Minor topics, HRT, menopause, no need to waste time. Please don't do all these topics. Okay, moving on to a very important similar list for our obstetrics. Okay, something to do with placenta and its variation may come. Trisomy 21, again extremely important. Dual marker test, triple marker test, amnio, CVS, confirmatory test, all that. Definitely the questions are coming. Everything to do with antenatal trisomy detection. Early pregnancy sonography, USG in early pregnancy, again very important, equally important. And then the important part is your test for fetal well-being, that is the NST and BPP, biophysical profile. Okay, then three most important topics which we should focus on: postpartum hemorrhage, antepartum hemorrhage, that is your abruption placenta previa, both extremely important, and of course pre-eclampsia, eclampsia, hypertensive disorders. Okay, malpresentations also equally important, mainly on breech. So that is how I have selected the question. In this video we are going to discuss questions of PPH also, something about APH also, pre-eclampsia, eclampsia also, breech presentation also, maneuvers I'm going to discuss. Okay, so these are the really important topics, and please do not forget ectopic pregnancy. So if you see, of course, so mainly trisomy 21, placenta may or may not come, ultrasonography in early pregnancy, something to do with the drugs. Okay, NST, BPP, PPH, APH, instrumental delivery, forceps vacuum. Again, we can get a MCQ on these also, we can expect. PEE is your pre-eclampsia, eclampsia. EP stands for ectopic pregnancy, breech, forceps vacuum. Okay, then yes, heart disease in pregnancy and diabetes in pregnancy also we may get a question. Twins, preterm, Leica disorders, oligopoly also equally important. So yes, obstetrics is huge, but this is the major thing. So minor topics like your PROM, postdatism, your other what you call medical surgical disorder, all that you can leave out, which are not very important. In medical disorders, we can focus mainly on heart disease, diabetes, and anemia in pregnancy as important. Pre-eclampsia, eclampsia, ectopic, PPH, APH becomes very, very important. Twins and Leica disorders. Okay, IUGR, RH negative, all we have covered in our actual video lectures. But even if you don't have time, so twins, Leica disorders, and occasionally in your FMG, the questions on preterm are also coming. Okay, so this becomes a very important list for obstetrics, specifically with the focus on trisomy 21, NST, BPP, postpartum hemorrhage, antepartum, that's your abruption and placenta previa, pre-eclampsia, eclampsia, malpresentations topic, ectopic pregnancy, instrumental delivery, heart disease, diabetes, twins, Leica disorders, and preterm. So these are the main. Of course, then on abortions also the question may come. Thrombophilia, something we are going to discuss. Questions have started coming on this. Okay, so this would be the major topic here. Also, don't forget, when I say contraception, also don't forget about the MTP. We are going to discuss about the latest guidelines and the new things all of you should know for the upcoming exam. Okay, so how can you do all this thing in the next just in the next 2-3 days time? Okay, so what you can do is you can focus, of course, and start revising these important topics as I have given you, because majority questions are going to come from this. And the best way to cover all this in a very short span of time, hardly 1 to 2 days, is going to be this MVP must know rapid revision course. And trust me students, majority of the questions in your FMGE paper are going to come from this course, is my guarantee. And it is just only 910 rupees. Promo code is available, and this is going to give you 15 to 17 hours of top quality MCQ discussion. It is only MCQ discussion, rapid revision of all the important topics, clinical cases, one-liners, images. And trust me, if you see at 1.5x speed or even 2x speed, then you just require 8 hours, and that is in 2 days, 4 hours. We don't require even your whole day time. Okay, just 3 to 4 hours, 4 hours on one day and for gynecology, and 4 to 5 hours another day for obstetrics. And trust me, you will be completely prepared for your obstetrics and gynecology, and OBGY will become your topmost scoring subject in the upcoming FMG, is my guarantee. Because as I've said, that students have told me that sir, every year questions are coming from your lecture only. So based on lots of experience, I've created this rapid revision course. It is going to be only 15 to 17 hours, and only MCQs are going to be discussed. Best and the most important, these are the must know MCQs. Few of them are virgin MCQs, and of course all the PYQs are also covered in this. So it's just going to be around 15 to 17 hours of discussion, and you can easily, if you see at even 1.5x speed, in 10 hours, 5 hours, and in 2 days time, trust me student, in 2 days time you can revise your entire OBGY with the help of this rapid revision package. And it's extremely cost effective, and it's only 910 rupees. So definitely do subscribe to the app, download the app, and start revising your package, and you can start with the revision preparation right away. Okay, so with this as the background, now let us go. So I've told you about the must know important topics in gynecology and most important topics in obstetrics, and questions will be coming from these topics. And now let us begin some of the very important MCQ discussion, very likely for the upcoming exam. And do stay till the end, because images are also going to be covered. Okay, I love match the column kind of question, very important. And I've tried to pick up the questions based on the important topics only, what I told you. Yes, so these are the various conditions. This is the karyotype, and we need to match which the karyotype is for which condition. Okay, so Turner syndrome. And why I like match the column so much, it's also a new style of asking question, because in one question you get 4 MCQs discussed. Clap if you feel happy. So in this next 2 minutes, 4 or 5 questions will be covered for all of you. So Turner syndrome is 45XO, all of us know. So one is going with A. So it's either A or B. Automatically 2 options are ruled out. One is not C, one is not E. Okay, yes, very important. By the way, something important, what is the most common cause of primary amenorrhea? Yes, Turner syndrome is also the most common cause of primary amenorrhea. When you have primary amenorrhea, the most common cause is Turner syndrome or your 45XO. Okay, so Turner's is the most common. Another name for Turner's is gonadal dysgenesis. Okay, so whatever is in the option, you can mark that as the answer. This is the most common cause. Okay, the second most common cause is RMKH, Rokitansky Meyer Kushner Hauser, also called as your Mullerian agenesis, and these patients have a karyotype of 46XX. And third most common cause is androgen insensitivity syndrome, and these patients have a karyotype of 46XY. Okay, so these are the 3 most important also the causes of primary amenorrhea. And also all of you should know the change in the definition, of primary amenorrhea, which has happened. The older definition was 14 years and 16 years, and now this has come down by 1 year each. Older definition was that if the patient does not get periods by 14 years in absence of secondary sexual characters, and 16 years in presence of secondary sexual characters. Now this is changed, and 14 has become 13 years. So absence of menses till the age of 13 years in absence of secondary sexual characters. And 16 also has become 15 years. Okay, so if secondary sexual characters are present, Then, and by the age of 15 years also, if the patient has not got her periods, we label her as primary amenorrhea. So again, I'm surely expecting this question. So new definition of primary amenorrhea is 13 years and 15 years. 13 years is in absence of secondary sexual characters, and 15 years is in presence of secondary sexual characters. Okay, presence of secondary sexual characters. Okay, so this is the new definition, and these three I also revised for you, the common causes and the karyotype. So now RMKH is what? Yes sir, it is 46XX. So 2 is C, 1A, 2C, and you have your answer. 3 is going with the androgen insensitivity is XY. So 3B, and Klinefelter is of course 47XXY. So it is not 4E, and it is not 3 is not C. Okay, so this is wrong. 2 is not B. So this, yes, so this is wrong, and this becomes our answer. Okay, so option number B is the right answer, and definitely do get this correct in your exam. Okay, moving on to the next MCQ. So with every MCQ, I'll try to give you a lot of other extra important information also, that I discussed the three most common causes of primary amenorrhea, 1, 2, 3, in order of frequency, and the new primary amenorrhea definition also I gave you. Moving on to the next, hysteroscopy indicated in all of the following except. Yes, so this is very, very important. Please understand, in hysteroscopy, we are evaluating, we put in a telescope through the cervix, and I evaluate the uterine cavity. Only the cavity of the uterus can be seen. Okay, so what is done is that through the cervix, through the patient's cervix, we put in a telescope and we are able to see the inside of the uterus. So mainly the focus is on the uterus ka cavity. Okay, uterus cavity is very well seen with the hysteroscopy. Okay, so point number 1, if there is intrauterine adhesions, what is it called as? Yes sir, Asherman syndrome. Very popular MCQ, surely coming. So if there is intrauterine adhesions called as Asherman syndrome, hysteroscopy will not only diagnose it, hysteroscopy can also help in treatment. Yes or no? All of you can see how I can do a surgery through hysteroscopy, and what I can do, hysteroscopic adhesiolysis, and I can break the adhesion. See, I'm doing a surgery. See, a surgery is being done and we are cutting all the adhesions, and the adhesiolysis done, cavity became normal. Okay, so hysteroscopic adhesiolysis can be done. Similarly, if there is a septum, if that is a septate uterus and there is a septum inside the uterus, then also hysteroscopy helps in not only the diagnosis, also simultaneous treatment. Again, I can do hysteroscopic septal resection. I can keep on cutting the septum, keep on cutting the septum, and that is our hysteroscopic septal resection. Or if the patient has got severe menorrhagia, then there could be a polyp or there could be a fibroid inside the uterine cavity, which are going to cause menorrhagia. So all this septum and Ashermans are going to cause infertility. Okay, septum and Ashermans are going to cause infertility as well as repeated miscarriage or abortion also. Okay, the septum can cause even repeated miscarriage, and there could be a polyp or there could be a submucosal fibroid, which are going to present to us as menorrhagia as well as infertility. And again, we can also do the surgery. So please understand, hysteroscopy advantage, it is not only for diagnosis, it is also for simultaneous management and treatment of the condition. I can cut the polyp. We can do a hysteroscopic polypectomy, hysteroscopic myomectomy. So now when I look at the question paper, hysteroscopy is for Asherman syndrome. Of course, yes sir, diagnosis and management. The question is all except. Menorrhagia patients also, yes sir, like sir, polyp can cause menorrhagia, thickened endometrium could be there. I can also take a biopsy. So polyp, fibroid, it could be endometrial hyperplasia. Endometrium is thickened. Okay, thickened endometrium. Of course, hyperplasia is the diagnosis under the microscope on histopath, but we can take the biopsy and see if there's any hyperplasia or not. And infertility patients also, because all those things what I told you, the septum, adhesions, fibroid polyp can also cause infertility. So A, B, C, all patients as and when required, we will do hysteroscopy. Adenomyosis is the answer. Why? Can anybody tell me what is adenomyosis? Sir, adenomyosis is presence of endometrial glands, okay, presence of endometrial tissue and endometrium within the myometrium, okay, within the myometrium, and for that you require either ultrasonography or MRI, because what is going to happen, what is the typical USG feature? So we are going to see multiple cystic spaces, okay, multiple cystic spaces or glands, multiple cystic spaces or glands within the myometrium. And as I told you students, hysteroscopy is only for the uterus cavity. Yes, so hysteroscopy is only for the uterus cavity. Anything if there's a problem over here where the cross mark is there, if there is the problem, then hysteroscopy can help. In adenomyosis, the glands are within the myometrium. These are glands, endometrial glands are within the myometrium. So they appear as multiple cystic spaces scattered throughout the myometrium, and therefore for adenomyosis you require ultrasonography or even MRI for the diagnosis. Okay, so don't make a mistake. Really, it's a very important question. And with this 3-4 things: management of septum, septate uterus, hysteroscopic septal resection; management of Asherman syndrome, hysteroscopic adhesiolysis. Okay, moving on to the next question. Yes, so it's a mix of obstetrics, gynac, so that you don't get bored. Some gynac questions, then obstetrics, then gynac ops. Okay, very important. All of the following maneuvers are used to deliver the after coming head of the breech, except, so for after coming head of the breech, point number 1, the baby is delivered out. We hold the baby by the lower limb and rotate it up onto the maternal abdomen. Okay, so this is the example, the fetal head which is still inside and the baby is out like this. We will hold the baby by the lower limb and rotate it up towards the mother's abdomen. So when you rotate the baby in a long arc, the head will come out from here. This, my dear student, is the Burns-Marshall maneuver. Okay, is the Burns-Marshall maneuver. Similarly, there is a Morrissey-Smellie-Wheat maneuver where with the left hand, details not expected at your level, only for my love for the subject I am teaching you. The left hand will give malar flexion and with the right hand you give shoulder traction. So clap if you feel happy. How to remember this is, sir, what is done in MS maneuver? Morrissey-Smellie-Wheat. So MS maneuver. So in MS, you do MS. In MS, do MS. MS, in MS means the first one. MS is what? Sir, in Morrissey-Smellie-Wheat, in Morrissey-Smellie, you do MS. You do MS means what do I do? Sir, we do malar flexion and shoulder traction. That's it. Clap if you feel happy. So MS, do MS. Malar flexion, shoulder traction. And then similarly, a Wigard-Martin maneuver also. Okay, Mac-Roberts maneuver is the answer. Anybody? Very, very important. Mac-Roberts is a maneuver for shoulder dystocia. When the shoulder gets stuck, hip hyper, you hyperflex the maternal hips and thighs onto the maternal abdomen. Mac-Roberts maneuver, dear students, is for shoulder dystocia. It is not for after coming head of the breech. So Burns-Marshall, Morrissey-Smellie-Wheat, Wigard-Martin are the maneuver for the after coming head of the breech, and the Mac Roberts maneuver is for shoulder dystocia. Okay, there is a special forceps and other maneuvers also we will discuss in the actual lectures also. Moving on to the next important MCQ. Yes, extremely important. That's what I told you. Trisomy 21. Okay, all are USG features of Down syndrome except. Okay, now please understand, sir, this is seen, this is seen, this is seen, this is seen. Yes, sir, all are seen. Yes, please understand this. Point number one, first of all, yes. Do we get duodenal atresia? Yes, that is the double bubble sign. Double bubble sign. Three more also I will tell you. Okay, three more also extra features I will tell you, which all of you should know. Anybody, what is a sandal gap? So sandal gap is a gap in the baby's between the great toe. Okay, so the baby's great toe is like this, and second, third, fourth, fifth digit is like this. Okay, so there is a gap between the great toe and the remaining. So great toe could be like this. Okay, the great toe could be like this, and the remaining digits of the foot could be 1, 2, 3, 4. Okay, 1, 2, 3, 4, 5. Yeah. Okay, so this is the sandal gap. So duodenal atresia, double bubble sign, very, very important. Sandal gap could also be seen for Down syndrome, or that's our trisomy 21. And sometimes within the heart, if it's a 4-chambered heart, it's a PG level thing. But yes, we can get a echogenic intracardiac focus. We get a bright white color spot inside the heart, which is called as a echogenic intracardiac focus. But three more important, which all of you should know: increase in NT. What is NT? Increase in nuchal translucency. Okay, increase in nuchal translucency and absent nasal bone. All these are extremely, and even omphalocele. So duodenal atresia, sandal gap, echogenic intracardiac focus. You also get echogenic bowel, increase in NT, absent nasal bone, omphalocele. All these are really my very important. Increase in nuchal translucency also, increase in nuchal fold thickness also. Okay, mental retardation, my dear student, is seen with Down syndrome, but that cannot be picked up on USG. Please understand this. Please understand, USG is for structural problem. If the brain has a problem, okay, like example, corpus callosum is absent, or there is some brain problem, then all the structural problem can be picked up by USG. USG cannot about the functional problem. So the baby will be born, we can only say brain structure normal. After the baby borns and the baby is scholar, Albert Einstein, gold medalist, or duffer and failure, and last bencher, that sorry sir, we cannot make out. So mental retardation is a feature of Down syndrome, yes, but it is not diagnosed on ultrasonography. Okay, USG can diagnose duodenal atresia, sandal gap, echogenic cardiac focus, and increase NT, absent nasal bone. Option number 4, mental retardation, is the answer. It is a feature of Down. Similarly, simian crease. Okay, so simian crease is also there, but that cannot be picked up on sonography. Okay, sonography can pick up the structural problem. Okay, so even simian crease is a feature of Down syndrome, but mental retardation is not picked up on ultrasonography. Okay, moving on to the next very important MCQ, and surely expected that as per the new guidelines, now MTP is allowed till how many weeks of gestation. Okay, so all of us know that MTP was allowed till only 20 weeks of gestation, and now the upper limit has been raised to 24 weeks of gestation. But specifically we should know, and also the other amendments and changes also I will tell you know, I'll let you know. But specifically we should know that which condition this 20 to 24 weeks jump. Okay, so now the answer is 24 weeks. Exception is there. One exception I'm going to tell you. Okay, don't miss out. So sir, this 20 to 24 weeks jump or the change was done for 2-3 conditions. Sir, mainly certain structural anomalies in the baby are picked up sometimes later. that baby has some severe heart disease which could be diagnosed, suppose at 22 weeks, 24 weeks, some diagnosis is made for some fetal anomalies, or sometimes the genetic testing that sir baby has trisomy or chromosomal abnormality could also be delayed. And second, of course, very important, if she is a rape victim or social or your sexual assault victim, then that she might be late, hesitant to coming out and all that. So for specifically for victims of sexual assault and rape also, this change has been made. So for the mainly for the baby anomaly, if the baby has a problem, of course if mother's life is at risk, then of course definitely MTP can be done. And if fetal anomalies which are diagnosed later, and trisomy and chromosomal, and if there's any sexual assault or rape victim also, then we can do till 24 weeks, and mother having a problem. Remember student, there is a very important clause in our MTP Act, and that is also the most common reason why we do an MTP today, is failure of contraception, isn't it? So remember this, that for failure of contraception, this is still only till 20 weeks. Okay, if your condom has condom torn, or IPL failed, or emergency contraception failed, or whatever, if the OC pills, whatever, if there's a failure of contraception, you can't be sitting at home till 24 weeks. Okay, so failure of contraception is still up to 20 weeks only. Okay, so for the other three clauses, that's our baby has a problem, rape or sexual assault victim, and mother has a problem, only for these three conditions the limit has been raised from 20 to 24 weeks, because certain fetal anomalies may be diagnosed later, and chromosomal anomalies may also be diagnosed later, and these patients may come to us slightly later. So yes, the change has happened from 20 to 24 weeks, but this is for all the causes except for failure of contraception, which is still always till 20 weeks only the MTP should be done. Okay, so this is really very important, keep in mind. And how many doctors should certify? Yes sir, now as per the new guidelines, up to 20 weeks, only one doctor or one RMP doctor has to give his opinion of how many doctors, that yes sir, opinion that the MTP is required. And after 20 weeks, that is till 24 weeks, now two doctors have to sign and give an opinion that yes, MTP has to be done. Okay, so MTP allowed now till 24 weeks, but for which indications, keep in mind. Okay, 1 2 3, and mother having any problem, of course. Okay, moving on to the next important MCQ. And yes, again, surely this question is likely to be coming. It's a PYQ and surely coming. Patient has come to us with 45 days of amenorrhea and wants MTP. What is the best schedule? Okay, so total confusion. Don't make a mistake. I am going to give you also a trick. It is now a combi kit. A combi kit is available where there is one tablet like this and there are 4 other tablets like this. Okay, so this could also come as an image based question. Now point number 1, this medical method can be done up to how many weeks? Yes sir, 63 days or 9 weeks. 7 weeks was the old thing. Okay, up to 63 days or 9 weeks. Okay, till 9 weeks this medical method can work very well. Okay, 63 days or 9 weeks this can work. Now please understand, there's a total confusion. Point number 1, the drugs used are mifepristone and misoprostol. So automatically second option, we don't use methotrexate. MTX is out. Okay, MTX is out. Okay, now please pay attention. Okay, okay, now how are the drugs given and what are the drugs? Now the total confusion and what does each of the drug do also we should know. So point number 1, mifepristone is a anti-progesterogenic agent. Okay, mifepristone is a anti-progesterone. Mifepristone is anti-progesterone. Okay, so it will block the progesterone. anti-progesterogenic agent. So pregnancy stops growing, because if you block the progesterone, the baby cannot survive, the pregnancy stops growing. And it also primes the cervix to my action of the misoprostol. And very, very important, misoprostol is which one? Yes, sir, it is a PGE1 analog. It will make the uterus contract, cervix dilate. Okay, misoprostol. Now, sir, which drug is given first, which drug is given second? Totally, many students have a confusion. Simple, don't make a mistake. The answer is in the spelling itself. MI is same. Then what comes F? So MIFI is given first. Clap if you feel happy. Okay, F is there. And then look at your S. S is given second. Okay, so mifepristone is given first, and after 48 hours, misoprostol is the second drug which is given. Okay, so always remember that MIFI is first. So this option is again out, because sir, your meso is given first and MIFI after 48 hours. So this option also out. Now between A and C. Yes, and A and C, don't make a mistake. The doses are completely interchanged, and that's why only one of them is the answer. So mifepristone is a 200 milligram tablet, 200 milligram, which is given orally. Okay, 200 milligram orally, single tablet. Okay, so this is the mifepristone single tablet, mifepristone, and this is 200 milligram. And these 4 tablets are my misoprostol. Each tablet is 200 microgram. Each tablet is 200 microgram, and you can see 4 tablets are there. So total becomes 800 microgram. So not the first. Mifepristone is not 200 microgram and meso is not 800 milligram. So even that is out. So what is the answer? Yes, sir. What is the answer is option number C. Mifepristone 200 milligram on day 1 and misoprostol 800 microgram after 48 hours later on day 3. Okay, so by the way, and one more important point, so first we give mifepristone 200 milligrams orally, and then after 48 hours misoprostol is the second drug which you give, 800 micrograms. This can be given. Meso is a very multifaceted molecule. Sir, I can insert it in the vagina. We can give it per vaginal also. We can give it oral also. And we can give it sublingual also. Oral causes lot of nausea, vomiting. Even sublingual can cause nausea, vomiting, but that's okay because the tablet gets dissolved. So we can give it per vaginal, oral or sublingual. Even buccal is allowed. But traditionally, remember, PV route, yes, 800 microgram, or even sublingual or oral can also be given. So 4 tablets, 200 each, so it is 800 microgram. So MIFI, F aata hai, MIFI is first 200 milligram, followed by 48 hours later. So this is day 1 and then day 3. Day 3, the second drug, S. S is meso. So meso is the second drug, 800 microgram per vagina, and meso is a PGE1 analog. So the answer, mifepristone 200 milligram on day 1 and misoprostol 800 microgram after 48 hours. Moving on to the next MCQ. Absolute contraindication for IUCD is. So again, a very important decided topic of contraception and contraindications for IUCD. So please pay careful attention. Okay, so point number 1, remember that unnecessary the IUCD is blamed for ectopic pregnancy. Okay, IUCD does not increase the risk of ectopic pregnancy, and for past history of ectopic is not a contraindication. Similarly, past history of PID, acute PID. Okay, if there's an acute pelvic inflammatory disease, acute PID or a current PID, then in active infection, any active infection, I cannot insert IUCD. So if I have to put down the absolute contraindications of IUCD in a table form, remember, 1 is acute pelvic inflammatory disease, second puerperal sepsis. Okay, puerperal sepsis, because any sepsis, infection, current STDs, all that. Okay, so puerperal sepsis. What else? Okay, remember after vesicular mole, after we evacuate a vesicular mole, this was also one of the previous MCQs, because after V mole, the uterus is very soft, there is increased risk of perforation. Okay, so a V mole, after V mole evacuation, we should not put in a IUCD. And two most important, remember, distorted cavity. If there is, or uterine anomalies, like example, all of you see this bicornuate uterus. How will I put? Which side the copper T? How can I put a copper T? Because if I can go only one side, other side still. So uterine anomalies, like specifically bicornuate uterus, or if there is if this is the uterus and there are multiple fibroids like this, then you can see that the cavity becomes distorted. You will see how the cavity has become like this. Okay, so the copper T will not fit properly. Okay, so these are my distorted cavity, uterine anomalies, cervical cancer, CA endometrium, all these, and undiagnosed vaginal bleeding. If there's undiagnosed vaginal bleeding, we do not know what is it, then also, and of course, pregnancy is understood. Pregnancy, CA cervix, CA endometrium. So these are my important list of absolute contraindications. Remember students that, remember student that menorrhagia and dysmenorrhea both are relative when we talk of copper. Okay, menorrhagia, dysmenorrhea, both I will avoid but can insert. The question is about absolute contraindication. Menorrhagia and dysmenorrhea are relative contraindications for a copper containing IUD. Undiagnosed vaginal bleeding is the answer over here. So not past history of PID, acute PID. Past history is again a relative contraindication. Ectopic, no connection. Undiagnosed vaginal bleeding is the answer over here, and menorrhagia, dysmenorrhea is my relative contraindication. Okay, so acute PID, puerperal sepsis, undiagnosed vaginal bleeding, of course, obviously pregnancy, CA cervix, CA endometrium, following a V-mole evacuation, uterine anomalies, and distorted cavity. Okay, then the copper T will not fit. Okay, by the way, please understand that which IUD, and there's also image at the end, which IUD I can give in treatment of menorrhagia, dysmenorrhea. Yes, sir. LNG intrauterine device, in fact, is used in treatment. LNG IUD will make the menorrhagia better, dysmenorrhea better. So LNG IUD is in fact good for my patients of menorrhagia, dysmenorrhea. Okay, but when they say IUCD, they mean generally copper T. And undiagnosed vaginal bleeding is definitely the absolute contraindication. Menorrhagia, dysmenorrhea is a relative contraindication for our IUCD. Okay, for a copper containing IUCD, LNG IUD can be inserted in menorrhagia, dysmenorrhea patients. Okay, so moving on to the next very important MCQ. Yes, one topic of infection, one MCQ surely comes. Grayish white vaginal discharge with a positive whiff test. So what is it? Yes, this is a Gardnerella infection, and also called as bacterial vaginosis. Okay, so bacterial vaginitis or bacterial vaginosis. Okay, so bacterial vaginosis. And what is this whiff test also I will tell you, and what is clue cell. So two important things we should know. It's whatever secretions are there, and to that if I add 10% KOH, we get a fishy odor. And why do we get a fishy odor? Because of release of amines. So this is my whiff test. So whiff test is vaginal secretions plus 10% KOH, giving rise to fishy odor because of release of amines. And another very famous MCQ, clue cells. Anybody, what is clue cell? So they are vaginal epithelial cells loaded with the organism. This organism, this Gardnerella, the cocobacilli, it is adherent to the cell, and the whole cell is studded with this cocobacilli. Okay, so vaginal epithelial cells, it's loaded with the organism, that is clue cells. So remember, these are two extremely popular MCQ. Presence of clue cell and whiff test positive are both for my Gardnerella infection or bacterial vaginosis. And of course, what is the drug of choice for this condition? Metronidazole. Okay, metronidazole is the drug of choice for both my Gardnerella as well as for trichomoniasis also. Okay, trichomona infection also, metronidazole is a drug of choice. And fluconazole orally or locally, even clotrimazole. Okay, clotrimazole can be used for which one? Yes sir, for candidiasis. And one more important MCQ regarding bacterial vaginosis, that sir, it is because of imbalance between the good and the bad bacteria. So for bacterial vaginosis, partner treatment not required. Partner treatment not recommended or not required. Okay, in which infection? Sir, only in bacterial vaginosis, partner treatment not required. For trichomoniasis and candidiasis, both we need to treat both partners. Okay, we need to treat both sexual partners, we need to treat, otherwise the infection will keep on coming back. But here the partner treatment not required in bacterial vaginosis is also a very important MCQ. So with every MCQ we are discussing 2-3 extra MCQs, okay, for your benefit. Moving on to the next MCQ. Yes, a virgin MCQ likely for the future. The best marker for ovarian reserve is. First, I will tell you, if only these four are the options, what is the answer? And if I add one more option, what becomes the answer? But majority students do not know what is the meaning of the word ovarian reserve. So ovarian reserve simply means what is the capacity of the ovary to produce eggs, or like what is the bank balance, that if the egg, if the ovaries, if the ovary has got lot of eggs, many more years of fertility left in the ovary, that means many eggs are remaining, then we call it as a good ovarian reserve or optimal or satisfactory ovarian reserve. But if the capacity of the ovary, if the capacity of the ovary to produce eggs is going to become less and very few eggs left in the ovary, then we call this as a diminished ovarian reserve. Okay, so simply it basically means what is the capacity of the ovary to produce eggs. So for here, what we use the marker? Yes, FSH, because remember, pituitary is the master and ovary is the servant. So FSH is a marker for ovarian reserve. What do I mean by this is, please pay attention, that if somebody's FSH is normal, if some patient's FSH is normal, very good, that means there is a very good ovarian reserve. It's a good ovarian reserve. But if now the ovarian reserve, if the ovarian reserve keeps on becoming less, what is happening? So the ovarian function indirectly is decreasing. So if the ovarian function decreases, the master will shout more loudly. Yes or no? Ki baba kaam karo, work. And therefore FSH will rise. And therefore increasing FSH is a sign of diminished ovarian reserve. So simply remember student, ovarian reserve means what is the capacity of the ovary to produce eggs, and if the capacity of the ovary to produce eggs is lesser, it is called as diminished ovarian reserve. And what will be the effect of this? Okay, sir, the brain or the pituitary will have to secrete more FSH, and therefore rising FSH, that means the FSH value is very high, 10, 12, 14, 16, okay, 12, 14, 16, all that tells me more than 10 that it is a ovarian reserve is becoming less. And when ovarian reserve completely over, okay, diminished matlab ovarian reserve is becoming less. And when complete ovarian function stop, that is what? Yes sir, that is then menopause, isn't it? When ovarian function completely stop, that is menopause. At that time FSH is going to be very high. FSH is going to be high, even more than 20, 30, technically more than 40. So when the FSH is in the range of 40 and above, that means patient ovarian reserve already over, patient has reached menopause, and FSH is very high, 17, 18, 19, 20. It means it's almost like patient is approaching 20 and more. The patient is almost like diminished ovarian reserve and menopause. Technically menopause, FSH is going to be more than 40. So rising FSH tells me that there is a diminished ovarian reserve. 3 to 10 is considered normal. So more than values you don't have to remember. So 12, 14, 16, 18 FSH values if you get. And remember, FSH should always be done on day 2 or day 3 of the cycle. On the menstrual cycle, we do FSH on day 2 or day 3 of the menstrual cycle. Okay. You cannot do any time. Okay. On the menstrual cycle, day 2, day 3, this FSH testing has to be done. Okay. But suppose, so if this is the answer, FSH is the answer. FSH done on day 2, day 3 of the cycle. Okay. And if the FSH is normal, that means the patient has got a normal ovarian reserve. Okay. Or a good ovarian reserve. Okay. FSH normal, patient has good or a normal. And FSH rising, that means it is a, yes, diminished ovarian reserve. DOR, diminished ovarian reserve. But if the option I change, and I add one more option, AMH, this MCQ is surely coming. AMH stands for anti-Mullerian hormone, and it is a newer and a better marker. Okay, newer and better than FSH. So AMH is better than what? Better than FSH as a marker for ovarian reserve. And therefore, if the question is best marker for ovarian reserve, then actually AMH is the answer. Okay, so option E, which I have added, E, much more better answer, E much more than C. Okay, so if AMH is anti-Mullerian hormone, and AMH comes from the small follicles, the primary follicles, which in the future, AMH comes from the ovaries only. Okay, AMH is secreted from the ovaries. AMH is secreted from the ovaries, from the small primary follicles, which in the future will become mature follicles. Only point to be kept in mind is, so AMH is a newer marker and better marker, better than FSH as a test for ovarian reserve, or is a better marker, and therefore it's the best marker. AMH is the answer, E. If E is not in the option, then mark FSH. I repeat, if FSH and AMH both are in the option, go for option number E, FSH. Go for AMH. Okay, so AMH is a newer and better than FSH. The only point you need to keep in mind is it's a rising FSH is telling me diminished ovarian reserve, but the AMH is coming, so this is the inverse relation. What is the inverse relation? Okay, sir, as the ovarian reserve is going down, this arrow down, this arrow is going up, but AMH is a direct correlation. That means low AMH. Okay, lower the AMH, because AMH comes from the ovary. So low AMH tells me diminished ovarian reserve. Okay, so clap if you have learned something new. I repeat that high FSH, high levels of FSH and lower levels of AMH both point to the one thing, diminished ovarian reserve. Or when the ovarian reserve is diminished, we will get this in the blood test. Okay, but AMH better. AMH is better than FSH as a marker for ovarian reserve. And if the question is best marker for ovarian reserve, the answer is AMH. So AMH better than FSH as a test. So therefore E much more than C. If only these are the option, FSH is the answer. If AMH is in the option, AMH is the best marker for ovarian reserve. Okay, moving on to the next MCQ. Yes, again match the column kind of thing and lots of important information. Okay, so Burns-Marshall I discussed in the video. Burns-Marshall is for after coming head. After coming head of breach is understood. So one is going with C. So one is C or one is C. One is not A, one is not E. So automatically two options directly ruled out. Wood's maneuver. I told you Mac Roberts maneuver is for shoulder dystocia and Wood's maneuver is also for shoulder dystocia. One more, remember, when the shoulder gets stuck. Okay, so 2 is going with F. 2 is going with F. And can anybody tell me, I told you APH, short topic. APH is a short topic. Please keep in mind, always one APH will come. MCQ will come, 1 or 2. And can you tell me abruption placenta previa, how to differentiate clinically? Yes, it's a very important lecture. Abruption is mainly a painful bleeding. It is a painful bleeding and the uterine tone is going to increase, tonically contracted uterus. Placenta previa, very popular MCQ. It is a painless bleeding. Okay, and when I go for a conservative management in placenta previa, that means I can wait and watch in placenta previa, admit the patient, give steroids and bed rest. That is McAfee and Johnson regime. So 4 is B. What is 4B? Sir, McAfee and Johnson regime is a conservative management. When I do conservative management, that means I wait and watch. When I wait and watch in a patient of placenta previa, that is McAfee and Johnson. And what is Cuvier uterus? 3A. So Cuvier uterus 3A. So perfectly correct. This becomes the answer. 1C, Burns Marshall after coming head. 2F, Woods maneuver, shoulder dystocia. 3A, yes, Cuvier is for abruption, and McAfee Johnson is for placenta previa. Okay, so this option number D is the answer. Again, 4 questions discussed with this one MCQ. Now what is Cuvier uterus is? It's just a blood goes back flow. Okay, the blood goes back flow. Okay, sir, if this is the uterus and it is a abruption, the placenta has detached. The placenta has detached. Okay, but the placenta is completely blocking the blood from coming out. Okay, the placenta is completely blocking the blood from coming out and the blood is all getting accumulated behind the placenta and the blood is not able to come out. So then what will the blood do? Sir, blood goes retrograde in between the muscle fibers, into the myometrium, in between the muscle fibers. And what will happen? Sir, what will happen is that the uterus will start appearing bluish purplish in color. Uterus will become bluish purplish in color, which is called as, so the uterus is appearing bluish purplish in color. This is the diagnosis which you make on operation table. Okay, uterus will be bluish purplish in uterus. That is called as that is the Cuvier uterus. That is the Cuvier uterus. Okay, that is the Cuvier uterus. So it is seen with concealed abruption. C. Cuvier uterus seen with which abruption? Concealed abruption. Okay. Just remember, blood goes retrograde into the muscle fibers and uterus will appear bluish purplish in color. And what is the treatment for this? Sir, will you tell the operation theatre sister, sir, sister, give me Surf Excel, Nirma washing powder, and will you wash the uterus? No, nothing needs to be done. Okay, the uterus, if the uterus is well contracted, nothing needs to be done. This will automatically get resolved. So please don't remove the uterus, and there is no need to wash the uterus with Nirma and Surf Excel and Ariel washing powder. Okay, just keep it as it is. This will get resolved. It's like if how you get a bruise. When you get a bruise, your skin will change color. After few days, this uterus will start appearing normal. Okay, moving on to again a clinical case. We have a patient who after delivery of the placenta starts to bleed heavily. So what it is after the delivery of the placenta, if there is heavy bleeding, of course, sir, this is PPH, postpartum hemorrhage. And on examination, the cervix and the vagina are healthy. but the uterus is flabby. What is the uterus flabby telling you? What type of PPH? Yes, sir, it is atonic PPH, because sir, PPH could be atonic PPH where the uterus is flabby, and or it could be traumatic PPH. And traumatic PPH means, sir, uterus is very well contracted. Okay, here what happens? Uterus is well contracted. Uterus is well contracted, but there is so uterus is very well contracted, so there's no bleeding from the uterus. But in traumatic people, the bleeding is from the cervix and the vagina. Yes, there could be cervical tear, vaginal tear, all that. Okay, so here all of the following drugs can be used in management except. Okay, so what are the drugs in management of PPH? Yes, point number one, oxytocin is the first drug of choice. Okay, so we always, you start massaging the uterus, oxytocin can be given. And the question is all except. And even methergin or methyl ergometrin can be given. Misoprostol per rectally we insert. Okay, so misoprostol also can be given. PGE1, that is, and even PGF2 alpha can be given, carboprost. So all these, and absolutely 100% coming for sure in this exam, FMGE as well as NEET PG, carbetocin. What is carbetocin? Answer is clear cut, mifepristone. Mifepristone, I told you, has nothing to do with PPH, isn't it? Mifepristone is an anti-progesterogenic drug I use for MTP. Okay, so that's the answer. All of the following are used in management except mifepristone. So anybody, what is carbetocin? Yes, sir. Carbetocin, as the name suggests, oxytocin, is a newer drug available for management of PPH. But the advantage of carbetocin is it is heat stable. It is stable at room temperature. Stable at room temperature, and it does not require refrigeration. Oxytocin needs to be kept in the fridge and refrigerator. Okay, so remember, oxytocin, the cold chain has to be maintained, and you need to keep oxytocin properly in the proper temperature, otherwise it will lose its potency. But that is the advantage of carbetocin, that carbetocin is stable at room temperature. Carbetocin is stable at room temperature. So all are used in management of atonic PPH except mifepristone. Moving on to the next MCQ, again a clinical case and again very likely to be coming. Recurrent abortion a patient has got at 8 weeks, 11 weeks. And next time there was very much early onset preeclampsia in the next. Which is the most probable cause? Very, very important virgin MCQ for FMG, likely to be coming. Now please understand, cervical incompetence will always cause abortion in the second trimester. Yes, cervical incompetence will always cause abortion at 16, 18 weeks, mainly 16 to 18 to 20 weeks, mainly between 16 to 18. Here our patient has abortion at 8 weeks and 11 weeks. So we have got first trimester abortion. Similarly, and also early onset preeclampsia. Okay, similarly, torch infection may cause one abortion but will not cause repeated abortions, and there is no connection with development of preeclampsia. And GDM, gestational diabetes, develops only at around mainly 24 to 28 weeks, isn't it? Gestational diabetes again develops mainly at around 24 to 28 weeks. So it cannot cause abortions in the first trimester. Gestational diabetes cannot cause. Okay, so yes, what it is this? This is antiphospholipid antibody syndrome, APLA syndrome, or also it could be thrombophilia. Okay, so thrombophilia could be hereditary or congenital or acquired. And acquired thrombophilia is antiphospholipid antibody syndrome, APLA syndrome. Okay, acquired thrombophilia is your Apla syndrome. And remember, Apla syndrome students, 3-4 main clinical features. Sir, Apla syndrome can cause abortions. It can cause abortions anytime, but mainly in the repeated first trimester abortions, as in this case. Okay, and very, very important, it can also cause early onset preeclampsia. What's the meaning of early onset? Sir, immediately after 20 weeks. Like preeclampsia is always after 20 weeks. But preeclampsia generally patients develop at 28, 32 weeks. Here, if the patient starts developing preeclampsia right from 21 weeks, 22 weeks, 24 weeks, it is called as early onset preeclampsia. Third, the patient can also develop severe IUGR. All these are features, and also sudden IUFD. So if they tell you patient also had a sudden IUFD, third time, 36 weeks, suddenly the baby died. And lastly, it is also known to cause abruptions. So trust me, clap if you have learned something new. These 5 are the features. Repeated first trimester abortions. Second trimester abortion can also happen, but mainly abortions in the first trimester, or early onset preeclampsia, severe IUGR, sudden IUFD, and abruption. So here that fits in the history at repeated abortions in the first trimester, and also early onset severe preeclampsia. That is the antiphospholipid antibody syndrome, okay, or APLA syndrome. Moving on to the next important MCQ, and again surely coming, Fothergill's repair. Anybody? Fothergill's repair associated with all of the following except is the question. Okay, now whenever the fourth option is all of the above or none of the above, student directly mark that is the answer. No, that is not the answer. Okay, that is not the answer. Now anybody, Fothergill's repair is a surgery for what? Yes, it is one of the surgeries for prolapse, but it is very, very rarely done nowadays. We don't do it. Why we don't do it? Anybody? Because anybody, it was a surgery for prolapse for young patients, for prolapse in young patients. Fothergill surgery was done. What is the main step of Fothergill operation? Sir, main step of Fothergill operation is cervical amputation. Cervical amputation is the main step. So when I chop off the cervix, when we chop off the cervix, what can happen? The remaining part of the cervix. Okay. So basically we are going to, this is the uterus, this is the cervix, and we are going to chop off the cervix. Okay, in Fothergill, and a new cervix is created. Now this can either become too tight and can cause cervical stenosis. And if there is cervical stenosis, there is a risk of infertility, or during labor the cervix will not open up, which is cervical dystocia. Okay, but also the cervix can become too loose and give rise to cervical incompetence. Okay, so abortion topic also, we had cervical incompetence, and cervical incompetence, I told you, will always cause abortion in the second trimester. It is likely to be repeated, and what is the main thing? Repeated, painless. Yes, painless abortion in the second trimester. That is cervical incompetence. So it is always going to be abortion when? Sir, abortion in the second trimester and not in the first, which is our answer. So this, sir, यहाँ पे first trimester abortion दिया है. First trimester abortion, the causes are chromosomal, genetics, apla. Cervical dystocia can happen, and yes, even this can lead to preterm labor. Okay, cervical incompetence, repeated painless second trimester abortion, and even preterm. So preterm labor, yes, can happen. So basically, none of the above is not the answer. So cervical dystocia can happen, preterm can happen, cervical incompetence can happen. Cervical incompetence can happen, and second trimester abortion, not first. Okay, So that option A, because all except so first trimester abortions is not a complication of Fothergill. So Fothergill complications, hemorrhage, blood loss, cervical dystocia, even infertility, because patients will not conceive because of cervical stenosis. So remember, cervical stenosis will give rise to infertility and dystocia. Cervical dystocia. Cervical dystocia means during labor, the uterus is contracting but the cervix fails to dilate. And cervical incompetence can cause second trimester abortion and preterm labor also, because cervix can become too loose. Okay, so these are all the complications of Fothergill, and therefore Fothergill is almost never done nowadays. It's hardly ever done, and we don't do Fothergill's repair nowadays. So moving on to the next important MCQ, very important. 47-year-old lady, 2 centimeter antral fibroid, menorrhagia since 3 months. Next line of management is, majority students, trust me, will directly mark hysterectomy. Wrong. Then many of you will mark myomectomy. Again wrong. Okay, because after so many years I can tell which MCQ what wrong also mistake or what mistake students will do. Please pay attention. This is a very important question, that this is our patient who is 47 years old, is a perimenopausal lady, and most important, a 2 centimeter anterior wall fibroid is just given to confuse you. A 2 centimeter anterior wall fibroid will never cause menorrhagia. Okay, so in this patient, basically we have a 2 centimeter anterior wall fibroid, which is just an incidental finding. This 2 centimeter fibroid is just an incidental finding, and it is not going to cause any symptom, and it cannot cause menorrhagia. So what is the rule? That, sir, why never directly do hysterectomy? Why never directly do hysterectomy? Because, sir, if I remove the uterus and then the histopath report is cancer, I have done an inadequate surgery. So what is the dictum? that, sir, in perimenopausal patient, whenever the patient is 45 plus or 40 plus, in a perimenopausal patient, peri-MP I am writing, HPE is mandatory. Histopathological examination of the endometrium is mandatory. Okay, mandatory means what? It is compulsory. Always, why I need to do histopath? Because remember, in perimenopausal patient, I need to rule out. What? Yes, I need to rule out endometrial hyperplasia and endometrial cancer first. Okay, endometrial hyperplasia and endometrial cancer always needs to be ruled out first, and then only we have to proceed for the treatment. So which hysterectomy will I do? Simple, radical, sada, masala, sada dosa, masala dosa, like that. So which hysterectomy I will do will depend on the histopath report. So never ever directly do hysterectomy. First I need to make sure what my diagnosis is, that, sir, what is there within this endometrium? Why is she having menorrhagia? And therefore DNC or a DNC, because that is your histopath. So I have to remove this lining, and that lining I have to go under the microscope and do the HPE. Histopathological examination is mandatory or compulsory. Please keep this in mind. Okay, so we always need to rule out endometrial hyperplasia, endometrial cancer first, and then only proceed for the treatment. Histopathology is mandatory, and therefore the answer is I need to first do either a DNC, or yes, we can even do hysteroscopy and biopsy. Okay, hysteroscopy and biopsy can also be done, but first, whatever lining is there inside, take it out and examine histopathologically. And then yes, so DNC will be the next line of management. And then again, myomectomy has got no role, removing this 2 centimeter fibroid. And generally in a 47-year-old lady, we don't do only myomectomy. Okay, myomectomy is done for young patients when you want to preserve the uterus. So first I will go and do a DNC, or I will do the histopath, that is by either hysteroscopy and biopsy. So whatever you do, sir, I can do a DNC, we can do endometrial biopsy, or what I told you the best is hysteroscopy. hysteroscopy plus biopsy is the best. Okay, so that is to be done first, and then depending on the report I will take a call. Yes sir, if it is hyperplasia with atypia or malignancy, then I can do a hysterectomy. Otherwise we should try to save the uterus. Okay, try to save the uterus. Okay, Indian government says save the tiger, save the cheetah. Doctors will say save the doctor. Yes, so whom to say? Save the doctor. Yes, save the doctor, save the intern, save the uterus, and save the tiger and the cheetah. Why? Because we also have an option of LNG IUD. LNG IUD or Mirena can be inserted in this patient also, provided there is no cancer. Okay, so DNC will be done first, and then depending on the histopath report, we can see different modalities of treatment are available, and then even hysterectomy can be done. I'm not saying don't do hysterectomy, but never directly do hysterectomy first. Okay, never directly do first hysterectomy. First rule out hyperplasia cancer, and then decide what operation or what management you want to give. So DNC or hysteroscopy biopsy is the best for any perimenopausal patient. It has to be done first, compulsory. Okay, moving on. Yes, very, very important screening test in second trimester for aneuploidy. Aneuploidy, that is our trisomy 21. All are done in the second trimester. Yes. So in the second trimester, what do we do? Sir, we do a triple marker test or a quadruple marker test. And the components are HCG, alpha fetoprotein, and unconjugated estriol. HCG, alpha fetoprotein, unconjugated estriol. That is done in triple marker, and quadruple marker extra this plus even inhibin A. Okay, so sir, inhibin A second trimester, because why? Triple marker, quadruple marker test are done between 16 to 18 weeks. They are done in the second trimester. Alpha fetoprotein is also a part of this. HCG is also the part of this. Yes, HCG is also used in the first trimester. In the first trimester, what we use? Yes, sir. In the first trimester, we do T1. I am writing. In the first trimester, we do a dual marker test or a double marker test, which is HCG and PAP-A, which is our answer. What is PAP-A? Pregnancy associated plasma protein A. Pregnancy associated plasma protein A is the answer, because sir, that is only done in the first trimester. HCG is done both. HCG is a part of dual and triple. So and quadruple. So HCG is also done in the second trimester. The question is all are done in the second trimester except, okay, so except PAP-A, because why sir? PAP-A is done in the first trimester. HCG, alpha fetoprotein, unconjugated estriol, inhibin, all are done in the second trimester. HCG is also done in the first, but PAP-A is always done in the first. Okay, so HCG, remember, can be done both. Sir, HCG is done in the first trimester also and also in the second. So that's not the answer, because it is done in second, HCG. Moving on to the next MCQ, and all these are screening tests for Down syndrome. Okay, PAPPA, pregnancy associated plasma protein A. Moving on to the next MCQ. Yes, Pritchard's regime when we give magnesium sulfate. So magnesium sulfate is a drug of choice for eclampsia. Three things what you monitor. When you give the patient magnesium sulfate. Anybody? Yes, knee jerks, respiratory rate, and urine output. Okay, knee jerks or deep tendon reflexes. Okay, so magnesium sulfate, drug of choice for eclampsia and severe impending eclampsia, knee jerks, respiratory rate, urine output to be monitored, and the therapeutic range, please remember, very, very important, 4 to 7 milliequivalents per liter. 4 to 7 milligrams per liter is the answer. And as the levels will become very, very high, 8, 9, 10, 11, 12, there will be toxicity. What can happen? Yes, respiratory paralysis and even cardiac arrest. And very, very important, what is the drug of choice for magnesium sulfate toxicity? Yes, sir. Magnesium sulfate toxicity, the drug of choice, calcium gluconate. Calcium gluconate is a drug of choice for magnesium sulfate toxicity. Very, very important MCQ, and 4 to 7 please by heart. At that range the convulsions are going to stop, and therefore that's a therapeutic level of Maxwell to be achieved. Moving on to the next MCQ, again very important topic of ectopic pregnancy. So which of the following is an indication for surgical management? That means what is the question is that, sir, in ectopic pregnancy we always prefer if the patient is stable and the other criterias are satisfied. That means, sir, if it is a unruptured ectopic pregnancy, methotrexate MTX is the preferred treatment. But for methotrexate there are some criteria to be satisfied, and if those criteria are not satisfied, then compulsory we will have to go for surgical management. So of course if it's a ruptured ectopic, pregnancy, I have to do surgery. But in unruptured ectopic with the three, so one criteria, it is unruptured, means the patient should be stable. Okay, patient if is HD, I'm writing hemodynamic stable. Then second, anybody, what should be the sac size for giving methotrexate? Yes sir, when I'm writing down the criteria for methotrexate, so gestational sac should be less than 4 centimeters, and that is our answer, that sir, if the size, gestational sac size is more than 4 centimeter, then sir, methotrexate MTX will not be given, and compulsory I will have to go for a surgical management. And second important, please pay attention, yes, it should be an unruptured ectopic for methotrexate. And third, preferably the fetal cardiac activity should be absent. It should not be a live ectopic. And very, very important, what should be the HCG levels? Yes sir, less than 5000 micro international units per ml. It means, sir, suppose if the sac size is around 2-3 centimeter, it is a stable patient and HCG values are 1000, 2000, then we can give methotrexate. So HCG should be less than 5000. So yes, HCG levels less than 1000, very good. Here I can go for MTX. Unruptured ectopic, I can go for MTX. Size more than 4, patient wants to continue, no, sorry, ectopic pregnancy you cannot continue pregnancy. Okay, it's good, it will rupture. If you continue, it will rupture for sure. Ectopic will rupture for sure. So which of the following is an indication for surgical management? That means which of the condition methotrexate will not be given, that is the question. So size, gestational sac size more than 4 centimeter, MTX will not work, and I will have to go for surgical management. Okay, moving on to the next MCQ. Yes, starting with the image based questions. Identify this image. What is this image? Sir, this is LNG intrauterine device. LNG intrauterine device, also called as LNG20, also called as Mirena. Mirena is a brand name. Now please understand, what does it contain? So it contains progesterone. Why I call it LNG20? Because 20 microgram per day is released in the uterine cavity. Okay. Now please pay attention. What will happen if it's going to release continuous progesterone, isn't it? Continuous. Mirena will be inside the uterus and continuous every day it's going to release progesterone. Progesterone means LNG. LNG is a progesterone. So progesterone will counteract the estrogen and will not allow the estrogen to act only. So what will happen? So the lining will not grow only. So the endometrium, because endometrium grows under the influence of estrogen. So because of continuous progesterone, what will happen is, let's say the lining is not going to grow, and the lining, endometrium lining, is going to remain very, very thin. And therefore what happens to the periods? Yes, sir, that is the main advantage. It's a period becomes scanty, 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 and periods can even stop. Nothing to worry. It's a progesterone induced amenorrhea. Because of continuous progesterone, the periods are stopping. So it is absolutely safe for the patient. Okay, it is like, so there will be no menses. It's like, sir, only if the lining grows, then the menses will happen. Lining is not growing only. It's like, sir, only if the beard is growing. Yes or no? Only if the beard grows will I shave. If the beard is not growing only, like Tiger Shroff, then what will I shave? Okay, yes, because when Tiger Shroff came, initially he didn't have any beard growing. Okay, now he has done some hair transplant and now his beard has started growing. Okay, we don't know why. Okay, but what am I saying is that, sir, only if the beard grows, then you have to shave. If the beard is not growing only, you don't need to shave. Same thing. Sir, only if the endometrium grows, then the endometrium needs to be shed off. If the endometrium is not growing only, there is no need to shed. So menses will become scanty, further scanty, and it can also stop. So therefore it is very, very important that it is going to help patients of menorrhagia and dysmenorrhea. And because of progesterone, it is all except. So can it give treatment of endometrial hyperplasia? Yes, sir. It can treat menorrhagia. It can treat dysmenorrhea, reduction in dysmenorrhea in patients of endometriosis and adenomyosis. Okay. So menorrhagia will become better, dysmenorrhea will become better, endometrial hyperplasia can get reversed because this is progesterone. Reduction in dysmenorrhea. And also very, very important point. Many students do not know this. Clap if you have learned something new. That it will protect against ectopic pregnancy also. Answer over here is option number 4, none of the above. All are benefits of this except none of the above. Now how does it protect against ectopic is that, sir, because of its progesterone action, also the cervical mucus will become thick. Because of progesterone, the cervical mucus will also become thick. Okay, so what will happen if the cervical mucus becomes thick? Sir, any infection in the vagina will not be able to go up. Infection in the vagina will not be able to go up, and the tubes will remain healthy. And fallopian tubes, if they remain healthy, it means PID episodes will become lesser, and therefore ectopic is protected, okay, or lessened or prevented. So very important, I repeat, it's, sir, because Mirena. What will Mirena do? Sir, Mirena will make the cervical mucus thick. So if the cervical mucus becomes thick, then indirectly PID episodes, pelvic inflammatory disease episodes, will become lesser. Why lesser? Because the infection cannot spread up, and therefore if the PID becomes lesser, then even ectopic will also become lesser. So decrease PID correlates to decrease in ectopic pregnancy, and therefore yes, LNG IUD protects against ectopic pregnancy. It's a very, very important point. Do not make a mistake. Next, very, very popular MCQ. What is this? We have got also a history that this is the ultrasonography of the ovary, and the patient was treated with ovulation induction medicine. Specifically, which ovulation induction medicine? Yes, sir. When we use either HMG, human menopausal gonadotropin, or recombinant FSH. What has happened? Some multiple big follicles have started growing, which is nothing but ovarian hyperstimulation syndrome. It is not PCOS. I'll explain to you why. But along with this, so what happens in OHS is that multiple follicles start growing inside the ovary, and all will become big follicle, 18-20 millimeter. But along with that, there should also be presence of ascites and free fluid. So this is a PYQ. This has been asked in the past, but actually along with this, they should give you one more picture. They should give you one more picture where around the uterus on USG, there is all free fluid and ascites. Okay, because fluid is black. Fluid appears black on ultrasonography. So around this, around the uterus, they should also give you one more picture where all fluid is there. That is your free fluid or ascites. Okay, this sonography picture should also be shown to you. That is actually OHSS. Yes, sir. OHSS is multiple big follicles in the ovary plus presence of ascites. Okay, so ascites is also there in your OHSS, ovarian hyperstimulation syndrome, and specifically with this history of ovulation induction agents. Now, can anybody tell me why it is not PCOS? Yes, sir. Don't make a mistake. PCOS, necklace of pearl pattern, where there are multiple small follicles and that arranged in the periphery. Okay, all small follicles when you are arranged in the periphery. So don't get confused. This is a difference is in front of you, sir, when you have got multiple big follicles. Okay, so big follicles all coming in the center, also multiple big follicles within the ovary with free fluid and ascites. That is OHSS and not PCOS. PCOS में thick echogenic stroma and multiple small follicles. Okay, multiple small follicles. Okay, on PCOS. So this very famous OHSS. And one more image we have got. Yes, what is this? Again, surely. So this is which view? Yes, this is the terrace view from above. So this is the uterus. We are seeing the pelvis. This is the ovary. And we have held this tube. This is the fallopian tube. So what is done over here? Yes, sir, in this, what is this image showing you? Rubin's test kachra dustbin, outdated. It was done many years back, where air used to be put and we used to hear for hissing sound and all that. Okay, so it's no longer done. Okay, this is not a laparoscopy tubal ligation. No, in laparoscopy tubal ligation we apply a band. Okay, and this is not a hysteroscopy view. With hysteroscopy I don't do methylene blue dye. Now what is this is that, sir, here we are seeing the uterus. So you put in a telescope. Okay, we put in a telescope into the abdomen and we are ready with our telescope. We are seeing the uterus and all that, and at the same time the assistant will push the methylene blue dye into the uterus. Okay, assistant will put the methylene blue dye into the uterus and the blue color dye. So what will happen is, suppose if this is the uterus, okay, this is the uterus and this is the fallopian tube. Okay, this is the fallopian tube. That is what is exactly shown to you in the picture, and the assistant will put the dye through the cervix into the uterus. So what will happen, dear student, is that the blue color dye, methylene blue color dye, will come into the uterus, and of course if the tube is spay, it will enter the tube, and from the fimbrial end of the tube the blue color dye will come out if the tube is patent, and this is called the spill of the dye, and everybody starts jumping in the OT. Blue hai pani. Okay, everybody is happy. Why happy? Because the tube is patent. So this is a laparoscopy chromopertubation. So this is the uterus, and all this blue color which you are seeing, this is the methylene blue dye. Okay, this is the methylene blue dye which is telling me that the patient's fallopian tube is patent, because we injected the blue color dye and it came out all the way from the uterus and it came out through the fallopian tube opening, fimbrial end. We are checking whether the dye is coming out of the fimbrial end or not. Okay, and if the dye, this is called as a spill of the dye. And by the way, this is the best investigation. This is the best investigation or gold standard. Okay, best investigation or gold standard for tubal patency, because with your own eyes, seeing is believing. Okay, so what are we doing, sir? We have put in a laparoscope, we are seeing the uterus, tube, ovary, and then the assistant puts a blue color dye and we are seeing whether that blue color dye is coming out through the fimbrial end or not. Okay, this is not a sonosalpingography. Sonosalpingography is a ultrasonography. Okay, so this is laparoscopy chromopertubation. This is the best investigation for tubal patency, because seeing is believing. With your own eyes we can see whether the tube is patent or not. So best investigation or gold standard. Suppose just an example. Okay, the blue color dye, okay, just an example, that the blue color dye will come here and will stop somewhere over here. The blue color dye is not coming beyond this. Yes, then you know that the tube is block. Okay, so this is how you can come to know. So if the blue color dye will enter the tube and will come all the way out of the fimbrial end, then the fallopian tube is patent. And the blue color dye stops somewhere in the middle, then the fallopian tube is blocked. Okay, so best investigation for tubal patency, laparoscopy chromoperturbation done with the help of methylene blue dye, which is injected into the cervix, and through the laparoscope we are checking whether it is coming out of the fimbrial end. It should come out of the fimbrial end. Okay, fimbrial end में से the blue color dye should come out, which is the dye methylene blue dye. Okay, yes, so this is our most important MCQs which I have covered. Majority questions will be coming from this in the exam, all the top most important topics. So this is like a ultimate revision program, and trust me students, I would request you, please go for this rapid revision course. Just 900 rupees and launch 30 offer and promo code is available. Must know virgin and previous years questions are there, and trust me student, just in 2 days time, in 2 to 3 days time, you will be able to master OBGY for your exam is my guarantee. And majority MCQs in your paper are going to come from this rapid revision course only. Trust me, when you start seeing the videos, it's just 15-16 hours, 16-17 hours, as I said, all clinical cases, image based questions, and one liners, everything is covered. It's a combination of must know MCQs, virgin MCQs, previous years questions, and within, if you see the videos at 1.52x speed, just 4 hours on one day, 4 hours on another day, 4 to 5 hours, and in 2 to 3 days time, if you just give 3 hours every day, in 2 to 3 days time, your entire OBGY will be finished, and well before the examination you will all be masters. Okay, so feel free to get in touch with me. I wish all of you again best of luck. Download the OGGURU app, and also you can give the mock test in the app, and also do subscribe to the YouTube channel. Wishing you all the best for the FMGE exams also. We'll also, once the question paper is out, and we'll also do a recall session for all of you with the FMGE MCQs, and I wish all of you best of luck. You will do very well. Focus on the list of the important topics which I have shown you. The list of important topics, please go through it, and every day try to prepare 2 to 3 topics. Okay, so again, I'll just one more time show you the list of the topic, and what you can do is that you can go and do 3 topics every day, and 2 topics if you do every day, then in the next 5 to 7 days time your entire preparation can be done. This is the list of important topics in gynac, and this is the list of important topics in obstetrics. Focus on doing, and you can do 1 topic of gynac, 1 topic of obstetrics, so that you don't get bored. Do 2 of gynac, 2 of obstetrics on one day. The next day again do 2 of gynac, 2 of obstetrics. Like that you can do the rapid revision. And as I said, of course, if you go with this package, nothing more is required, and you will be getting all the marks in your exam for FMG is my guarantee. Best of luck, and I will definitely be in touch with you through our videos and through our YouTube channel and through the app. Best of luck for your upcoming exams.